I'm lucky to be here with Dr. Piper, who has evolved in the TMJ world in the surgical side and the pain side, pretty much along the same time frame that I have on the occlusal side. And it's been, through the years, we've known each other off and on as we used to work together with the AES, but we never really had a chance to talk about occlusion as it relates to treating the joints. And through the years, obviously, there's been a lot of occlusal concepts that have come and sort of maybe gone, but I was curious to get your take on how you see occlusal therapy, how it's changed, and what it's meant to the kind of work that you do, and if you think it's an effective approach to deal with some of the TMJ issues.
Well, I really started as a very traditionally trained oral surgeon. And as you know, oral surgeons don't think too much about the occlusion.
Yes.
Okay, we would look at how we could fix it with an osteotomy. But I remember in 1983 when I decided to go to St. Petersburg, and I sat down with Pete Dawson and started listening to Pete about the occlusion. And a lot of his concepts really connected with me, and a lot made sense. My occlusion course in dental school was an hour, okay? And I think that's an hour more than most get now. But that's the reality. It was 1 hour, and they taught us about anterior guidance, and that was about the extent of it. So anyway, being exposed to Pete, it was a different world to me. And it made me kind of step back as a surgeon and look more critically at occlusal concepts and the benefit of treating the bite and so on and so forth. And what I got grounded in at that time was treating the centric relation. And that actually became a big part of what I was teaching when I was teaching at the Dawson Center. But then I would find patients in whom a fully seated condyle or so-called centric relation really wasn't the best treatment position. And we always had a concept of treatment position being a pain-driven posture of the condyle, okay? I always taught it, Pete always taught it, that if you couldn't get the patient fully seated into a comfortable position, that you would seat them as high as you could with reasonable comfort. So that became treatment position. And to be quite frank, in my paranoia as a surgeon treating temporomandibular joints surgically, I wanted to make sure I had all my bases covered. And so I took every MRI scan, fully seated position, every MRI scan, MIP, every MRI scan, incisal edge position, every MRI scan, open joint, because I knew what was going to happen. If I said, well, I had to go in and surgically repair this patient, somebody would have said, well, if you had just treated them to CR, they would have gotten better. Or if you had just treated them to MIP, they would have gotten better. Or if you had treated them down and forward, they would have gotten better. So what I knew from scanning was that I had every position documented, and it was mainly to buffer against criticism. Out of everything like that comes something good. And the good was that I now had thousands of image joints. And I knew exactly where the disc was in every one of these joints. And because most of my patients have foundational problems, I found out one thing that applied to the majority of them, and that was the fully seated position was not the best choice. And if I could just generalize from what I've learned from scanning and how I've evolved in the occlusion, it's really that we have a better foundation if we treat the MIP in damaged joints. We have a bite that's easier to treat.
Yes.
So perfecting that occlusion is easier. Getting anterior guidance from MIP is a whole lot easier from getting anterior guidance from a fully seated posture. And so I have to tell you, quite frankly, it was kind of like I was off in no man's land and on a point of discovery, looking for the truth on what imaging showed me in the foundation. And so that's kind of where I am today. There's been a paradigm shift that I personally have gone through because I think the reality for a patient long term is how we're managing their bite, but also from what treatment position, because that's going to have a big impact on whether that joint gets worse or whether that joint has a chance to hold its own long term. And I have to thank you, quite frankly, for, you've pointed out all these concepts to us during the years, and you've fought your own battles.
Yes.
And in your own way, you were outside of the mainstream.
Yes.
As was I. But what's very interesting is that two people from outside of the mainstream, conceptually, I think we're pretty close in terms of that conservative management with what we're doing to bites, what I would recommend for bites. And the nice thing to me is that the foundational concepts and imaging TM joints probably support your work more than anything else I know of.
That's interesting. So what would be the reason that you would think that, as far as the health of the TM joint related to the MIP position? And the reason I ask is because, as you saw earlier today, there was a lecture that discounted the need for MIP position as a helpful position. And we also have the history of MIP being not such a good position because it's perceived to be the reason that people have these problems, so they have to be moved out of that position. So in your frame of reference, what has, not the fact that we can treat the person simpler or the anterior guidance is easier to develop, but what is the value of MIP for the joint health?
It all gets back to medial pull. And you're either on the disc or not at the medial pull when you're in MIP. More people are under the disc at MIP than fully seated. We're talking injured joints, okay? Now, the joint's not injured, it's the same number. So we're subsetting these patients into those who actually have joint damage. And actually, it's very interesting, as you look at more forward condylar positions, the more forward the condyle, the larger the percentage of patients who are underneath the disc. Now, that doesn't mean that I recommend treating to an anterior position beyond MIP, because there are limitations in how far you can go with that. So we have a larger number of people with better alignment when we're at MIP versus fully seated in the injured patient population. That's one thing. The other thing is that, a lot of these people are locked. So they're locked out of place. The disc is no longer interposed. Instead, it's retrodiscal tissues. And what I find is that if we leave the patient in MIP, the retrodiscal tissues are more likely to kind of adapt themselves to that condylar position. And what's interesting is the condylar position in MIP is almost always centered in the joint, okay? I remember many, many years ago, there was an orthodontist in St. Petersburg. He never imaged joints. He took an x-ray, he centered the condyle, and that's how he finished his cases. I thought he was crazy. Because here he wasn't seating the condyle like we were doing. And the reality is that as I've done this imaging, that guy was right. I was wrong. He was correct. He had a higher batting average by treating the MIP than what he would have had he seated the condyles and retracted all the teeth.
So in the patient that has normal disc anatomy, the centering of the condyle on the disc is well positioned in MIP, and the person who's injured, who has a displaced disc anteriorly getting under the disc, is easier to do from MIP?
Kind of look at it this way. If the disc is normal, there's very little difference between CR and MIP. If the disc is damaged, we're more likely, as we're seating the condyle, we're more likely to deflect the condyle off the disc. If we treat them to MIP, we're more likely to stay underneath it. So if you look at progressive degeneration is in the disc, it's in the retrodiscal tissue, and it's in bone. And the more harmony we have in the alignment of the disc and the condyle, the less likely we're going to see that type of progression. And that simple concept of doing 4 different imaged positions to really buffer against critics has ended up to be very positive insight into that kind of old argument, do we treat to CR or do we treat to MIP? And I'll tell you, on injured joints, MIP wins, okay? 25 years ago, I never would have said it because I didn't believe it. I didn't have the imaging. I have the imaging now, and I think it's important to follow through on the reality of what that imaging shows.
Well, that's the essence of it. The measuring is what you're talking about, and the capability to see the truth, or more of the truth, through the data.
Correct.
And of course, the same sort of progression came from using the T-scan to measure the occlusion and to see how the physiology responded. And of course, we didn't have the knowledge of the joint changes, but it was always interesting to hear the patient say that their clicking went way down when they were discluded from MIP, or their noises in their ear went down if they weren't, let's say, clicking, and how they had a bigger range of motion, or they didn't notice as much difficulty translating or sliding left or right when they were coming in and out of MIP. And it was harder to do that from CR because I was trained to do it in CR in my prosthodontic residency, and also being a Dawson Pankey educated clinician through my residency. I didn't attend the Dawson programs or the Pankey programs, but my residency aligned with that idea. So we were manipulating the mandible. And when I started working with the T-scan, I found that it didn't seem to be as needed. And then I became, as you yourself, which I was unaware of, became an outlier because I was talking about, working against what people thought was really important. And you sort of came to it through seeing the truth through the imaging. And I sort of came to it through seeing the truth through the T-scan, because my education was to be in CR, just as your early occlusal education was to be in CR.
Yeah.
So that's an interesting thing. I didn't realize that you had gone through that sort of change to where you might not be aligned with the system of belief that had pervaded our profession.
Well, but it's not about it's not about others in the profession. It's about the patients.
Of course.
And I think the whole reason I'm still very excited in practice, and I'm sure you are too, is because you see the benefit to the patient on better outcome. Okay? As a surgeon, every dentist in America should have the goal of putting me out of business. I should never operate on a TMJ patient, because dentistry should understand foundational injury long before these patients need surgery, when we can still do very conservative things. And I kind of look at MIP as a very conservative thing, probably the most conservative thing that we can do when there's an injury to the medial pole. Okay? Now sometimes you have to go a little further. Maybe a couple of millimeters forward of MIP to get underneath the disc. Okay, I'm image-based. It depends on what the scan shows me. But what I've tried to share with you in this discussion is honest insight. And I don't mind saying I was wrong many years ago. There are things I say today I'll probably admit that I'm wrong about at some point in the future, but isn't that for the benefit of our patients too? Isn't that for the benefit of the profession to help the profession grow? And what's interesting, prosthodontist, surgeon, coming at this from different perspectives, but I think our message back to dentists is that there are more effective ways of treating than what we were doing 40 and 50 years ago.
Absolutely.
Okay? And the science changes, and you're correct. We measure now in ways that we never did before, and I think when that takes you in a different direction, you need to change course. Okay?
Well, some of us are willing to change course, others are definitely not willing to change course, which I'm sure you're well aware of. And
Absolutely.
And that's been a challenge in itself, because the public is the recipient of the benefits of these newer insights, but if they're not allowed to reach the dentist en masse, then the public is not able to receive them. So this is a problem that's beyond the scope of what we might be able to achieve, but it's been a barrier to the success of what we're each trying to do, because the dental community stands in its own way with these, holding on to some of the things from the past.
One thing I learned many, many years ago was that it doesn't matter what we do, there will be critics.
Mm-hmm.
But you shouldn't be driven by your critics, you should be driven by your success. And I think the patients speak to that success when we treat them. And again, what I see you doing by treating the MIP is you're part of that pathway of saying, okay, let's get these people better so they don't go to St. Petersburg and see a surgeon. And, that again is a feather in your cap. And, I think that we have to sometimes stand up for what's right, no matter how many believers there are, no matter how many critics there are. We have science and we have imaging. And I know in the long run, that's going to win out. Okay, it doesn't matter what people's opinion may be today. The science of what we have will point us and others in the right direction.
Well, that's why we have to keep going.
Absolutely.
Well, thank you for that.
Pleasure.
It was great. My pleasure.
Okay.